Yes, yes, doctor.
Fantastic. So I'm going to share my screen now. I will put on my video at the end when it's time for questions, but we'll get straight into it. So I assume everyone can see that okay?
Yes.
Fantastic. So I will start. Before I start, a very brief introduction about MRC. They really have been involved in, bear with me 1 second. Fabulous. So brief introduction about MRC for those of you who haven't heard anything about it before. They've really been involved in the treatment of all the various conditions that you can see on the screen now for about over 30 years. There is particular interest in the airway, so how the patient's airway, for example, sleep disorders, snoring, tiredness, obstructive sleep apnea, how these factors can go on to affect conditions that I would say better known for dentists, such as TMJ disorders or deficient growth and development, which can obviously lead to malocclusion. So as you can see at the bottom here, there are many different sorts of brands that we can focus and use to treat all sorts of different problems in the head and neck region. But today I'm going to be sharing and discussing one of these brands, which is the Myobrace system. And we'll go through the philosophy and then how we use the Myobrace system to treat these problems. So the title of this lecture is titled Myobrace Philosophy and Treatment System Overview. Just before I start or move any further, I know I've been introduced very nicely by you, Doctor, but I'll just give you a little bit of background about me. My name is Dr. Roochi Patel Sahi. I've been a dental practitioner, recently moved from the UK. I've only been in Africa itself since January this year. Very exciting move for me. I feel there's a lot that I want to bring to Africa, which is so advanced already in the dental field. I'm a certified Myobrace practitioner and provider, and I've been working with Myobrace for many, many years in the UK itself. So, if we move on, let's talk about what is myofunctional research. Who are they as a company? So I'm going to share with you their actual mission statement. And here it is. We develop simple, innovative appliance systems and education programs for health practitioners around the world to treat the breathing and myofunctional causes of malocclusion, TMJ, and breathing-related sleep disorders. So in a nutshell, this is pretty much what this lecture today and MRC in general covers. And these are really the main three conditions that we focus on. We have got malocclusion, which everybody knows, which is crooked teeth. It's got to do with poor growth and development on the face and the inability of the teeth, as you know, to fit. They also focus on TMJ disorders, the proper function of the TMJ joint, and also they focus on treating the breathing and myofunctional causes of sleep disorders. So dental sleep medicine is a particularly new field, and I know quite overwhelming for a lot of dentists, but it really is emerging in dentistry as a profession. The World Dental Federation in 2018 had released their own policy stating on this, which I will share with you today, but basically urged dentists around the world to get involved in the treatment of this. It is our responsibility to an extent to work as part of a team and manage dental sleep medicine sort of problems. So this company is focused on these avenues. The most important thing out of all of this to understand is that the common cause for all three of these things is breathing and myofunctional disorders. And that's going to make sense throughout this presentation. So just bear with me. So I'm going to race through this, But these are all the various things that MRC offers as a company. They help treatment on infants, they do interceptive growth and development. We have myofunctional orthodontics, which is the topic of the presentation today. We even help braces to work better. So a lot of people think this is an alternative to orthodontics and the way it's done conventionally. It can be true. The Myobrace system is an alternative method to approach orthodontic issues, but they've also got plenty of systems to help orthodontists and their braces work faster and more efficiently. Not ruling orthodontics out is key. We have solutions for orthodontists with retainers. So we have the retainers that work on the habits, and it also helps patients with TMJ problems after they've had something like Invisalign or Smiles Direct. The system works with patients just helping their TMJ problems, adults with their sleep disorders, children with their sleep disorders, and they also have adults that have an alternative to CPAP. So the company do a lot of stuff, and that's the typecast from a lot of people into the early orthodontic bracket. But as you can see, the company address many different things. They are on the website, myoresearch.com, and I will share that with you later on today. So you have access to investigate all these different avenues, which I know there are many. So the key points of all of this: malocclusion is growing in children, is approaching 100%. I mean, the vast majority of children have crooked or crowded teeth. Traditional orthodontics relapses without permanent retention. This is a fact, which I will show you a couple of papers about later. Now, orthodontics with clear aligners also relapses and can cause TMJ disorders. We've seen a lot of people come into our clinics after clear aligners with an array of TMJ problems. TMJ disorders also affect 50% of the population or more, I should say. Most doctors do not know how to treat TMJ disorder. I mean, I don't know about all of you, but it wasn't a pure focus in our undergraduate degrees, and I do feel that there is a gap. There is an estimated 1 billion adults out there that have sleep disorders, and now that's out of the Lancet journal. And so what MRC potentially is saying is they have the solutions in your practice for over 1 billion patients. In fact, 1 billion patients plus. There are so many people suffering from all of these problems, and they are coming through your clinics every single day. And MRC want to equip you as the practitioner, all the tools, all the education, the approaches to be able to treat all of these patients. These are all patients that need your attention. So in summary, there are 2 things which MRC do. And if you group all of these things together, we have myofunctional orthodontics, and then on the other side, we have TMJ, breathing and disordered sleep. But the topic of today's presentation is the Myobrace system, which falls under that myofunctional orthodontics appliance range. So before we get into the presentation, I always like to start with a little bit of history. Many of you will probably know this gentleman here, and if you don't, his name is Dr. Edward Angle. Dr. Edward Angle was the father of orthodontics. He founded the first school of orthodontics, and he founded the classification, the Angle's classification of class 1, class 2, and class 3 malocclusions. And here you see in 1907, he published this particular textbook that you can see in front of you. And there will be a page coming up, and as it comes up, I want to quote it for you. He said it was page 111, and we will be zooming in on that image in just a couple of more pages. Right down at the bottom here. He said, all of the various causes of malocclusion, mouth breathing is the most potent, constant, and varied in its results. So Angle recognized mouth breathing and the subsequent problems that mouth breathing cause on the muscles of the mouth as a major cause of malocclusion. Here we have William Prophet. Now, a lot of modern orthodontists would say that, okay, Angle, he was an idealist and his theories are sort of in the past. However, this gentleman here, William Prophet, is a highly respected modern orthodontist. He unfortunately has passed away about 3 years ago now. He is the chief author of a book called Contemporary Orthodontics. It's a textbook that is still taught today, and it's a major orthodontic textbook. And he published the paper in 1978 in the Angle Orthodontist, titled Equilibrium Theory Revisited. The factors that influence the position of the teeth. So he looked at what influenced where the teeth are positioned in the mouth and what causes the malocclusion. The conclusion of this paper was that the major primary factors in the dental equilibrium appear to be the resting pressures of the tongue and lips and forces created within the periodontal membrane. And then he goes down at the bottom right there to say, respiratory needs influence head, jaw, and tongue posture, and thereby alter the equilibrium. So what he means by that is that the means for breathing, the respiratory needs, influence the head, jaw, and tongue posture. So in order to breathe through the mouth, the head, jaw, and tongue posture need to change. That alters the way that the muscles act on the teeth, and then that is therefore the cause of crooked teeth. Now we fast forward all the way to the AGODO, which is the American Journal of Orthodontics, probably the most famous or most impactful orthodontic journal in the world. And in 2018, we are seeing papers like this in front of you now pop up almost every edition. Evaluation of pharyngeal space and its correlation with mandible and hyoid bone in patients with different skeletal classes and facial types. The significance of this paper is that we are now seeing orthodontic journals looking at problems to do with the airway and crooked teeth in almost every edition, the relationship between the airway and crooked teeth in every edition. Now, let's look at the first paragraph of the introduction. Craniofacial growth and occlusion are influenced, among other things, by the respiratory function, by the way a patient breathes. An impaired respiratory function, so that's the inability to breathe through the nose, is associated with airway inadequacy that can result in the habit of mouth breathing. So can't breathe through the nose, going to drop your mouth open and breathe through your mouth. This change in breathing pattern leads to lowering of the mandible and the tongue and an extended head posture, so that if you're going to breathe through your mouth, you're going to open your mouth, your tongue is going to drop from the roof of your mouth, and you're going to tip your head forward. Changes in normal airway function during the active facial growth period can have a profound influence on facial development by the time a patient comes for orthodontic treatment. So by the time a patient comes for orthodontic treatment, this has already played a profound influence on facial development. So the #1 orthodontic journal in the world sees the need to evaluate beyond the teeth. You cannot, in this day and age, just be looking at the teeth. And that is, in essence, myofunctional orthodontics, the whole topic of today's lecture. So I briefly alluded to this particular policy statement earlier from 2018 from the World Dental Federation, and they released this particular policy statement titled Dentistry and Sleep-Related Breathing Disorders. And what they basically said is that this paper was about the important role that dentists, all of you, play in the prevention, early screening and treatment of young patients with sleep-related breathing disorders. So sleep-related breathing disorders are a range of breathing disorders that affect patients during sleep. And they basically range anywhere from just mouth breathing to perhaps intermittent snoring, snoring more than 3 times a week, and upper airway resistance, which is like a resistance to air when you breathe in at nighttime. And then obstructive sleep apnea, which is the problem that everybody knows about when you stop breathing at nighttime. So it's a spectrum of problems, a range of problems, and it starts from mouth breathing. Yes, mouth breathing is a sleep-related breathing disorder, and it finishes all the way at obstructive sleep apnea. So let's look at what the FDI said. The FDI recommended that universities and national dental associations provide dentists and students with basic knowledge regarding the important role of dentistry in preventing and treating sleep-related breathing disorders, in particular, early detection in children and prevention of late onset forms. So first and foremost, I'd really like to applaud the UDA, the Uganda Dental Association, for even hosting this particular presentation, because it is now exactly in line with what the FDI actually recommend. All dental and medical health forms to include questions about the patient's sleep quality and related data to do with the screening of sleep-related breathing disorders, and dentists to provide proper information to patients to understand the process of screening, treatment options, and the role of the care providers involved. These two last points, medical health forms, before I was introduced to the world of MRC, was definitely something that I didn't feel I had the knowledge about, even though it was something that the FDI highly recommended. So we've talked about the what. Let's talk about the how. Before we do that, we have to talk a little bit about growth and development. Not always my favorite module, but for this, very, very relevant. So this book here you see on the left is called The Handbook of Facial Growth, and it was written by a gentleman called Donald Enloe. It's probably still one of the most major craniofacial growth textbooks that are taught in orthodontic schools today. And it certainly is at the start of contemporary orthodontics, which is by Will Profit. And I would say that Professor Enloe was very highly regarded and still is in this field of craniofacial growth. And in the book, he says, growth is not programmed within the bone itself or its enclosing membranes. The blueprint for the design, construction, and growth of a bone thus lies in the muscles, tongue, lips, cheeks, integument mucosa, connective tissues, nerves, blood vessels, airway, pharynx, the brain as an organ mass, tonsils, adenoids, and so forth, all of which provide information signals that pace the histogenic tissues producing a bone's development. That's a big statement. So what he is in essence saying is that within the bone itself, there isn't a genetic blueprint where the bone can say, oh, okay, I have to grow to this dimension. The bone simply receives signals from soft tissues that are surrounding it, and then that paces the bone's development. So although there are genes that sort of control bone growth, there is a feedback system that is happening with soft tissue all of the time, which is why we do see a lot of growth disorders when people have soft tissue disorders. So the key word here is the blueprint for the design, construction, and growth of a bone thus lies in the muscles, tongues, lips, and cheeks. And you only need to go to, I don't know, your local pediatric ward where children have things like muscular atrophy, etc. And you can see the difference in their bone growth to know that this is true. So shortly, I'm going to play a video for you now that explains mechanically how that can lead to crowding of the teeth. So there'll be a bit of an audio Please make sure your volume is on, coming shortly.
The mouth breather typically has the lips open most of the time. This makes the facial development narrow and long. The tongue tip pushes forward generally between the teeth, which do not contact during swallowing. There are many variations of this, but the elements are the same. The mandible moves back. The tongue action prevents correct arch development. A narrow V-shaped upper arch with crowding is the result. The backward movement of the mandible in swallowing compresses the TM joint, causing TMJ problems.
So this animation is showing how much forward growth is lost, and it highlights the lack of jaw space commonly occurring in a child that breathes through the mouth. So this is the mechanics, and if this occurs when a child is growing, like during the active or rapid growth phase of a child, if the muscles aren't doing the right thing, then you can now understand what can go wrong. So here's a slide to demonstrate that. So on the left, we see normal growth, and that is forward and downward. And we get, as we grow forward, we get more space for the teeth and the airway, etc. The second slide you see is mouth breathers. They go this way, they go downward and backward. And the last slide is reverse swallowers. They grow this way as well. Downward and backward. So as you're going downward and backward, you're creating less space for the teeth, and the tongue is now falling down, is dropping down into the oral airway as well. So like I mentioned, the lack of forward growth leaves less space for the teeth and the airway. And you can see this child here who is obviously grown incorrectly. You can see how much of the face is actually missing in this particular child, and that the tongue, the jaw, and everything has fallen back into the airway. So if we look right here, how much of this face is missing? There. And you can see that. That's where the teeth are, and here is the airway. A child has to maintain an airway and an occlusion to survive. Those are the two most important things that it has to do. So malocclusion is thus the compensation for this poor growth. So don't take it from me. Let's hear it from an orthodontist, actually, Dr. Barry Raphael from the USA. A video again coming up shortly for you from him.
Kids are walking around with their mouths open, their tongue hanging down away from the roof of the mouth, and this alters the way the jaws grow. So our faces are changing. They're changing in their size and shape, and teeth try to come in and fit into jaws that are undersized and just don't have a chance. Orthodontics pretty much overlooks that phenomenon and just looks at straightening the teeth. But one of the side effects of that kind of thinking is that when you don't have enough room for the teeth, often you wind up taking some of them out as part of the solution.
Great. So you can see there Dr. Barry reiterating basically what we were saying. So let's move on to how common is malocclusion? Do you actually need to care about this? So there are multiple studies now that show upwards of about 93% of children are suffering from some form of malocclusion. Now, that doesn't mean that every single one of these kids needs treatment. Maybe the majority of them actually do. But the fact of the matter is that that could be an indication for you to detect these breathing and myofunctional problems. And you can have a chance of improving this child's growth, improving their health and development. And also, by the way, as a consequence, helping them develop straighter teeth. So what it's potentially saying is almost every child in your clinic has a malocclusion. That's a very big statistic that we cannot ignore. So a lot of people will be sitting there and asking, so why not wait until we use braces? What's wrong with braces? Look, MRC itself has nothing against braces. They're an absolutely fantastic way to straighten the teeth. It's not easy to do braces, and orthodontists are superiorly highly skilled individuals. But there are some issues that we do need to talk about. So obviously, if the child doesn't keep their teeth clean, we do see a bit of enamel damage when the brackets are taken off. We know that 100% of teeth that are moved with braces suffer from root resorption. There is no exception to that. Every single one suffers from some level of root resorption. And that particular study that looked at that was only looking at moving the teeth over 4 weeks. So you can imagine, if you're looking to move teeth over 24 months, you know what the sort of effects of the roots on the teeth are then. So now the main problem here is permanent retention. Permanent retention has become the norm in orthodontic treatments for braces and Invisalign and clear aligners. Otherwise, relapse will occur as the myofunctional causes have not been treated. So orthodontists, are you ever questioning the reasons for retention? Permanent retention is an absolute necessity. Research shows that despite long-term retainers, many still relapse. So even after the permanent retention, we're seeing relapse. And this is an American Journal of Orthodontics study. So this is a section, as you can see on your screen right now, that's been taken from that study. The conclusion is here that our results suggest that occlusal relapse can be expected after active orthodontic treatment, irrespective of long-term use of fixed retainers. Basically, what they're saying, whether or not you use retainers, you can definitely expect some sort of occlusal relapse. So that's why MRC really started to create a few different products for orthodontists specifically to retain their cases using myofunctional retainers. It's not perfect. It's better to just treat the patient properly to begin with, but at least it will help, I guess, stabilize the case a little bit more by stopping those muscles pushing the teeth in incorrectly. So it can be argued that traditional orthodontic treatment has little long-term benefit, but really the problem that should be cared about the most, I think, is that the breathing and myofunctional disorders are not treated. And that is really, I think, the take-home message. So it's just focusing on the teeth. You may have missed the opportunity to really help this patient improve their growth and development and their health. So take-home message with orthodontics, that the breathing and the myofunctionals are really not treated. So this presentation is meant to take you out of the teeth aesthetic kind of thinking into the myofunctional orthodontics, which really is about treating the causes, having better airway function, more stability, better growth, better function, and obviously, as a nice consequence, straighter teeth. We don't ignore straight teeth. We still want straight teeth, but you need to treat the underlying factors as well. So I wanted to just define myofunctional orthodontics with you. Myofunctional orthodontics recognizes the causes of malocclusion as mouth breathing and myofunctional dysfunction. Myofunctional orthodontics acknowledges the limitations of all current orthodontic techniques: enamel damage, root resorption, permanent retention, and relapse. The Myobrace system was developed to treat the cause of malocclusion, the causes of malocclusion, and incorrect jaw growth, as well as align the teeth into a stable position while avoiding damage to the teeth. The primary goal of myofunctional orthodontics with the Myobrace system is to establish a better airway and nasal breathing, which gives added health benefits. And finally, this requires a new approach to patient management with education and habit correction performed away from the conventional dental office setting. So if we want to do this kind of treatment, if you really want to do this kind of treatment, we have to think differently about the way we're already doing treatment. And the dental and health consequences of ignoring the causes, ignoring the root causes, sets the patient up for a lifetime of maladies and can even be potentially life-shortening. So I want to demonstrate with these two cases here. So the girl here on the left and right came into the MRC clinics in about the year 2000. They both had the same malocclusion and the same causes. And you can see when I click right here that they actually are both swallowing with a reverse swallow. They both thrust their tongue forward and when they swallow. So they both have a malocclusion with an open bite caused by mouth breathing and myofunctional disorders. So the patient on the right did not have any treatment because the dentist said it's too early. So she went to her dentist who said to wait until she's older, we'll do braces and we'll intervene. But the girl on the left here was treated with one of MRC's earlier systems called the Trainer for Kids. We'll talk to you a little bit about those, which has since been superseded by the Myobrace for Kids. And we can now see the costs of ignoring the breathing on the myofunctional causes.
You sound like a secret spot time, don't I? Yeah. Yeah.
And head right back and swallow again. And smiling swallow for me.
Sorry about that audio, but this is the girl that was on the right, the girl whose dentist said to wait until she's older. She returns 12 years later for braces, and this is what we find. I'm going to go through it for you and break it down. The first thing is she's mouth breathing. You can see the myofunctional disorder. You definitely can see the malocclusion. She also presents with poor posture. She has TMJ problems. She grinds her teeth. She gets head and neck pain. She's got a deficient jaw. She has a deficient upper jaw and a deficient lower jaw. She's got sleep disorders as well. Now, the question is, if this patient had orthodontics with just braces, would she be any better? She'd probably have straight teeth, but do you think as dentists she would be any better overall? So let's have a look at the difference. So you can see that the girl here that was treated with myofunctional orthodontics on the left, and you can see her better facial development, the way her face is growing more healthily. And you can also see here, if I just change the slide, you can also see right here from the side profile, the profile has improved. The question is, who has the better airway? So why would we do myofunctional orthodontics? Well, there are all the things that we can develop or get doing myofunctional orthodontics with the Myobrace system. And they are, you can get improved development of the face, improved upper arch form with no extractions. You get, it uncrowds the lower anteriors with minimal forces. So always bearing in mind minimal forces. Class 2 and class 3 corrections also possible. Opens the deep bite and closes an open bite, also possible. Stabilizes without fixed retainers. Health benefits, better breathing, better airway. Now, many of you would be asking, how is it possible that one treatment approach can treat all these different types of malocclusions? The fact of the matter is that it's the same as if you go to a general physician and you're overweight. You've got all of these health problems as a result of being overweight. So let's say, for example, you've got cholesterol problems, heart problems, knee or joint problems, and by losing weight and fixing the cause of your problems, you see all these symptoms improve. You don't necessarily correct them all 100%, but you see them improved by losing weight. So that's the philosophy that Myobrace operates under. If you can get your head around it, by treating the causative breathing and myofunctional disorders, we see an improvement in all the different forms of malocclusion that I'm going to display, that are displayed in front of you today. So it's all about treating the causes. That's how you can achieve all these different things. Now, there's obviously logistical advantage to it as well. You get comprehensive myofunctional training, by the way, by using the Myobrace activities. 80% of your treatment can also be delegated in your practice to trained auxiliaries, so minimal time for you as the dentist. The appliance, I skipped over that, but you'll see it again repeated, is used for 1 hour daily plus overnight while sleeping. And it can also be used with traditional braces and aligners if needed. So it is a very adaptive system and very easy to implement into your modern clinic. I think there's more so a fear of implementing it into the clinic because we haven't been trained in it, but MRC is at the forefront, ready to change that for dental practitioners like all of us to really start to implement this into your modern clinic. So let's take a look at all of these things in turn. And here is an example of how it improves the development of the face. So used for 1 hour daily plus overnight while sleeping, and there's an absolutely marked improvement. We've also got here an example of improvement in the profile. Is the airway better? I think you can see the position of the teeth and the airway. And we can also see here an improved upper arch form with no extractions. That's obviously the result of getting the tongue into the roof of the mouth. Once the tongue rests in the roof of the mouth, you can see a nice development of the upper jaw and good stability. And you can see the lower teeth as well. They uncrowded by themselves. That's just by using the Myobrace and just correcting the poor swallow and getting the tongue up into the roof of the mouth. Absolutely no fixed retainers. So let's look here, class 2 correction. This can happen quite regularly, again, from treating the causes. Look, just tongue position, breathing, all the causes, and we see class 2 correction happen very regularly. We also see, not shockingly, class 3 correction happen. In this particular case, you can see this child, it took 2 years, and this class 3 malocclusion was corrected. 4.5 years on, teeth are still stable. Why? With no retention, because the habits have been corrected. So again, no fixed retainers. Here, we can also open deep bites. Deep bites are often as a result of the cause of deep bites, the tongue sitting between the back teeth. So you can open that bite, correct the tongue posture, and you can see the deep bite opens quite predictably. And you can also see an improvement in lower arch form. That's also from improving the muscular forces that are pushing in on the back teeth. And you can see how the lower arch has actually rounded out quite nicely. And again, just to reiterate, no fixed retainers. So let's move on to open bites. This was caused by the tongue pushing out through the teeth. When you've got the tongue to push up upon the roof of the mouth, the open bite closes and they generally remain pretty stable. I know it's generally very difficult to correct open bites in orthodontics and keep them stable, but with Myobrace, this has seemed to be much less of a problem. And again, no fixed retainers. So I want to talk to you about this particular girl, or this case was displayed in the AJO, the American Journal of Orthodontics, to demonstrate that you can combine the MRC appliance with braces and achieve some wonderful, wonderful results, as you see here. So the conclusions were: a 10-year-old girl with class 2 div 1 malocclusion characterized by severe maxillary incisor protrusion and an underdeveloped mandible was successfully treated with a T4B. That's a trainer for braces and MRC appliance and fixed appliances. The myofunctional training contributed to correcting oral habits and establishing muscular balance. The occlusion of the facial profile were effectively improved with good post-treatment stability. So you can see that on the left, and the right is 4 years after treatment. And it's all of those things that I just mentioned, reiterated by the American Journal of Orthodontics. So improved development of the face, class 2 correction. It opened the deep bite, stabilized without fixed retainers, and like I said, published in the AGO deal. So this particular study, I'll just pop it all up on the screen for you, was published by Luca Livrini in the Journal of Clinical Pediatric Dentistry in March 2018, looking at the Myobrace and Myosa appliance for sleep disorders in children. And the results at the bottom suggest that the Myobrace or the Myosa functional appliance can be an alternative to mild to moderate obstructive sleep apnea in children. So what you've got to remember is obstructive sleep apnea is the severe form. So if you can help children with severe sleep disorders, then you can help children with mouth breathing on the regular. All of these children, mouth breathers. Okay, so let's look at some common symptoms to detect in your patients. After this slide, I'll pause for a few minutes. If any of you would like to take a photo of it or a screenshot, it's the things that you'd see day to day. So I decided to put in some young patients here because it's the best time to detect these problems. This is really what I want you all to start thinking about. So you can see here, this is an underbite, insufficient spacing between the teeth. The teeth ideally should have about 2 to 3 millimeters of spacing across them. So you've got the insufficient spacing, you've got the open bite, we've got narrow arch forms, an overjet of over 1 millimeter, so a horizontal discrepancy there. You've got a deep bite over 1 millimeter, crowding, incisal crowding, crowding of the upper teeth, grinding. We all see grinding very often. Enlarged tonsils. Make sure you really do look in the back of the mouth. This is a big problem with airway, obviously, and really needs attention. And enlarged tonsils are sometimes overlooked. You've got crossbite, so the upper jaw biting inside the lower jaw, and also anterior gingivitis in the front, common symptom of mouth breathing. So I'll pause for a couple of seconds. You can take a photo of this particular slide so you know what myofunctional symptoms to detect in your patients. Any of these are things that the MRC would love to take to the next level in the growth and development of the child. Right. I hope you all got that. You can also take a picture of this, but these are some of the extra oral things to look for, like an open mouth. I like to go and peek into the reception to look at what the children are doing when they're sitting waiting to be called into the surgery. An open mouth, a deficient lower and upper face, things like a tongue tie. If the tongue is stuck to the bottom of the mouth, it just can't get into the roof of the mouth to develop the upper jaw. So we also see venous pooling, bags under the eyes. That's a symptom of breathing problems. Of course, allergies and stuff as well, but definitely related to breathing related sleep disorders. So a reverse swallow, you can see the lower lip pushing against the teeth. That's a problem when the kid swallows. And also pushing the tongue forward like a tongue thrust, that's also another problem. And obviously poor posture as well. There are plenty of studies that show mouth breathing will make you tip your head forward, and that imbalances your spine, and that can cause a harmful posture. So obviously not all bad postures are related to mouth breathing, but it is definitely a sign.
The reverse swallow is typified by the strong lower lip contraction. This is pushing back against the natural direction of growth. The reverse swallow is typified by the strong lower lip contraction. This is pushing back against the natural direction of growth. Right, so moving on now, let's talk about how we evaluate it. And I'm going to move on to the myofunctional orthodontic evaluation. So we use the myofunctional or the MOE to have a look at these children. And these are the key indicators that we have to look for, okay? You're particularly looking at the arch form. You're
going to address facial development. You're going to look at mouth open posture, very important, incompetent lips, and finally snoring or bruxing. These are the common key points that we use when we are diagnosing any myofunctional disorders. So there are 3 sections to the MOE, and there's the dental section, the functional section, and also the breathing section. So you've got the dental, the functional, and the breathing. So I'll go over it a bit slower for you. Let's look at the dental section first. The dental section looks at dental alignment. So you're talking about the crowding, the spacing, proclining, retroclining of the teeth. The arch form looks at, of course, the shape of the arch form, whether it's flattened or narrow. Oh, sorry. The occlusion looks at whether there is a deep bite and an overjet. So all these things. Hi, Adam. I don't know if you can hear me. Hi, Adam. Fabulous. I think maybe he switched it off. So I'll just continue. The occlusion. The occlusion is looking at whether there is a deep bite or overjet, etc. So there's all these things that we assess in the MOE. We also look at whether there are deficiencies in the mid and the lower face and how the face is grown. So dentists are actually quite good at seeing these things, and you can see some examples here. This girl in particular has crowding of her lower teeth. There on the left, and she has a deep bite occlusion. You can see her facial growth is deficient, the lower and the upper face, and these things are the things that we tend to look for. So you can see here that she's got a deep bite. Now, the things that dentists need to look for a bit better are breathing, tongue, swallow, and lips and cheeks. So these are some of the symptoms that we look for. In breathing, we're looking for mouth breathing while awake, poor posture. When we're looking at the tongue, we're looking for poor tongue posture, lingual frenum attachment, so tongue ties, things like that. If the tongue cannot operate properly, then it cannot rest in the roof of the mouth. I've said this quite a few times. Then this is what we want to know so that we can correct it. Obviously, the swallow pattern, how the child is swallowing. We also want to know how they are behaving with their lips and cheeks whilst they are at rest. So because dentists aren't that trained at looking at function, you can relate the function to the dental situation. So let's look at it this way. If a child is not breathing correctly, the tongue drops from the roof of the mouth. So the orthodontic result is the arch form is narrow. And that ties in here to the arch form for the tongue. So you know that if the arch form is narrow, the tongue is not sitting up there. So if the patient has an occlusion that is a sort of an overjet or even tip back of the teeth, you know that the swallow is now incorrect because the swallow is pushed back on the teeth. Again, if the lips and cheeks are tight, then you know that the teeth, the lower teeth are going to be crowded. So the point of this slide really is to say, don't worry, with a little bit of training, you will understand the patient's function. But in the meantime, you can relate function to the way that the patient's teeth are so that dental alignment and arch form directly relate to the function. So very briefly, let's discuss the Myobrace appliances. So far, you've evaluated the patient. They've got a problem. How does the Myobrace actually help? So first and foremost, we're going to hear once again from Dr. Barry Raphael.
Well, what Myobrace does is look at those underlying causes and tries to deal with them. We teach kids to breathe through their nose, keep their lips together, keep their tongue resting on the roof of the mouth so the jaws can grow in their proper and full size. Then there's plenty of room for the teeth, and often the teeth will come in straight even before you get to the brace.
So again, by putting the Myobrace appliances in and getting the child to just close their mouth, the Myobrace appliances have features that push the tongue up into the roof of the mouth. And also while the child is wearing the Myobrace, they have to breathe in through their nose. So it refrains the patient to adopt incorrect habits and adopt the correct habits. So it's not an orthodontic appliance. The key thing to know here, it's a training appliance. It trains the muscles to do the right thing. And as a result, like Dr. Barry said, the teeth come through straight as the child is growing, usually before you even get to the braces. So let's look at the key features of Myobrace appliances. We have the tongue tag, which encourages the child to put the tip of the tongue into the roof of the mouth. That guides their tongue into the correct position. You have the tongue elevators, which lift the body of the tongue into the roof of the mouth and encourages the tongue to rest correctly. You have this dynamic core that's in all the appliances, the second stage appliances. It gives a bit more rigidity to the appliance, which helps to develop the upper jaw. That's backed up by the muscles, which hold the expansion. And then you've got the lip bumpers down here at the bottom, which discourage the lower lip from pressing against them swallow, and obviously the breathing holes. And the high sides, they hold the cheek and lips away from the teeth, and that develops the upper jaw. So it allows the jaws to actually develop. So they're all used for 1 hour a day and overnight. And they all the Myobrace appliances assist in correcting breathing and myofunctional habits. So a question we get asked all the time, I certainly do, is it only for mild cases? So this is a little interesting case put in here for you guys, just so that I can explain. A lot of people out there question, so what about severe cases? Is Myobrace only for mild cases? Now, this is 100% disclaimer, not for beginners. You'll want to refer these out until you're comfortable, but I just wanted to throw it in here to show you what is possible. This case is one of the most severe malocclusions that was seen in the MRC clinic. So if I just move on here, they fitted an upper BWS, and this is the way they expand the upper jaw. I'll just catch up with you there. And combined with the Myobrace, you can see the lower incisors are improving in alignment. And in January, this was the most recent update from the patient. So the patient with severe crowding to this. If anyone says that Myobrace is just for mild cases, it's very obviously not. But it's really the benefits that go beyond the straight teeth. And I think really we all need to care about. It's more of a holistic approach to dentistry. So this is a sleep questionnaire that we give the children. And you can see that everything is ticked yes, or there's a lot of things that are ticked yes. The child had a lot of sleep disorders, breathing disorders, and not even 12 months into treatment. And I'll pop up the follow-up form, and these things, most of these things are now no. And that's really something. Anyone can just straighten teeth. Well, not anyone, but it's all the other things that we achieve using the Myobrace system that is really of interest. And what a good or great thing that we can do here by improving a child's dental alignment, but also their dental function and the way they grow and breathe. So I want you to hear this testimonial from the parent, because it's the best system for patients, parents, and practitioners. So I'm just going to let you listen to her view.
So first of all, her snoring.
Yeah.
She doesn't snore anymore.
At all.
At all.
That's great.
There might be a slight sound, but it's not, as I wish I could actually demonstrate how bad she was, but not at all anymore. She is confident. So we're about 1.5 years into it, and she's got her confidence back.
That's so good.
So quality of life, 100%. I think that's about it. Her teeth are amazing.
Yeah.
Complete turnaround. She had a very, very narrow top and bottom, and now it's quite oval shaped. So they're probably the biggest things.
Yeah.
Okay, so one thing I really love here is that the mom said all these things snoring, confidence. And then right at the end, she said, oh, geez, the teeth, I forgot about the teeth. At the end of the day, parents care about their children growing up healthy and functioning correctly. And the teeth are a nice side effect on the side. So this is a lovely interview. It really highlights what you're doing with the Myobrace system. So let's not worry too much about this. I've said a lot and we've learned a lot today already, but I just wanted to mention to you that as you go through the paces and learn about myofunctional orthodontics, the next step is for you to move to bigger ideas such as pediatric health, sleep disorders, TMJ disorders, and even potentially chronic pain. And MRC really does have solutions for that. You can treat the cause of sleep and TMJ disorders without performing orthodontic techniques. So there are some non-orthodontic appliances that you can see on the screen. And these are some of the Myosa appliances, and all of those are on the website. So if you'd like to read up about any of those later, please do. And as I promised, a bit earlier, this is the website, as you can see right at the top there, www.myoresearch.com. Please click on it, register. There are free courses, online courses, a taster course that talks about the foundation of the philosophy. You can potentially start practicing, teaching your patients and parents and educating them about why you are incorporating their sleep concerns into your practice almost immediately after you register and even watch that first lecture. But I really hope that I've offered you some form of confidence that as dental practitioners, you do have a duty of care, but more than that, there are a lot of patients that are walking into your clinics every day that are potential cases where you can really make a difference. So thank you very much to the whole of the UDA and all of the dentists that came. I will stop sharing the screen and I will switch on my video. And if there are any questions, I would absolutely be happy to take them. Great. So this is me. Let me just adjust this camera a little bit. I'm not very good at, I'm not sure where you're going to pop the questions. If anybody wants to switch on their microphone and ask me anything, I would be very happy to answer any questions that you have.
Maybe we have one hand up. We have a hand up.
Yes.
Yes. Welcome, Dr. Aisha Batalingaya Sekalala. Actually, before she starts, she's an orthodontist. It's one of the few orthodontists we have in this country. So welcome, Dr. Aisha Batalingaya Sekalala.
Thank you, Dr. Matovu. Thank you, Dr. Patel, for your presentation. Very, very interesting. I don't know where to start with my comments and questions, but I think I'm going to start from the premise that all malocclusions are caused by breathing problems. I know that that is not really what you were saying, but in a way that's sort of what came through in one of the slides which said myofunctional orthodontics recognizes the cause of malocclusion as mouth breathing and myofunctional dysfunction. And I just wanted to point out to my colleagues that it's important, the importance of diagnosis. Diagnosis is very, very key. Cephalometric analysis is very, 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 very key because most of the studies that you have quoted are American studies based on Northern European children or young adults or adolescents of Northern European descent. So these are Americans who are mostly from Northern Europe, and most of the causes, the predominant cause of the skeletal malocclusion in these patients is a retrognathic mandible, which comes with all the characteristics that you have mentioned, whilst the African patient is primarily either bimax or a maxillary prognathic and a near normal mandible. So for this patient, mandibular advancement is with a myobrace or any other functional appliance for that matter is probably going to make us look worse. We might end up looking like our cousins from Bwindi For those that know, Bwindi is the place with the mountain gorillas. So we don't want to end up looking more biomarks than we are. So it's important that while you are diagnosing for your patient, you look at the key characteristics. Dr. Patel, I like the slides that you put up. In fact, all the children that you put up were Caucasian or of Caucasian descent. And primarily you could see that the right diagnosis was made and the right treatment plan was done. Because these patients with retrognathic mandible, yes, the tongue falls down. Yes, we need to bring it up. We need to advance it. We need to advance the jaw in order to correct the breathing problems. Now, our patients are different. And colleagues, it's important that you take that safe. It's important that you do your case analysis so that you can have the right treatment. I've seen patients who have had the Myobraces and really not for the face. And it's ended up making those patients look worse as opposed to improving them. I personally use the Myobrace a lot for finishing for my patients who are skeletal class 2, and I use it to maintain that skeletal correction, even for adults. So it works very well. And also for training for patients who you want them to start getting used to some form of an appliance before you get in. I've treated a few pseudo class 3s and patients who posture their mandible and end up in a sort of a class 3 profile in their early and mixed dentitions, and they work well. But my colleagues, I want to emphasize the importance of diagnosis. And for open bite cases, the ones that are a result of habits, yes, please, let's go ahead and use this appliance. But those that are high angle cases, where there's an increased vertical maxillary excess, the Myobrace or any other functional appliance for that matter is only going to increase that high angle and make them worse. So those, I'm trying to make them as my few comments, but thank you so much for your presentation. And the emphasis here, the take home, is diagnosis, treatment planning, and also to accept that there will be cases that will not be treated with this approach, and for you to be able to tell the difference. Because our grandfather of orthodontics, Angle, his approach was non-extraction at whatever expense. And then we know the problems that came with that. His students like Tweed said, no, we need to look at the face, because a lot of the Angle cases, they were not necessarily the right diagnosis for him to treat non-extraction, all of them. So I think the take home is to have a blanket treatment for cases. If you haven't quite done your case selection, it's easy to fall flat on your face. I know that's not a question, but it's a general comment around myofunctional appliances.
Thank you.
All right. Thank you very much, Dr. Aisha Batalinga Sekalala, for the clarification. Dr. Roochi Patel, there's a question from Dr. Bakabulidi Joseph.
Yes.
It says, in adults, at what age does Myobrace stop?
So I very much respect the previous doctor's comments, and myself, I have been in the UK doing Myobraces until just January this year, and I have since seen non-Caucasian patients since I have been here. I think the fundamentals of orthodontics, and perhaps my mistake coming across too within the realms of orthodontics, is really Myobrace is not a functional appliance. In fact, that is the realm of orthodontics diagnosis. And like I said, orthodontics is highly complex. And in terms of the myofunctional appliances, I think the key difference is its focus is on habit correction. So whether you've got clients or patients, with displaying with all those considerations that she said in the non-Caucasian clientele, it's obsessing the habits. I think that's just the bottom line. So into adulthood, I see cases pretty much all day, every day of venous pooling, mouth breathers, people who are not sleep apnea, but they're snoring. These are all real concerns. So yes, the one aspect that I think touches a nerve is where you consider Myobrace for straightening teeth, and certainly in adult patients to address that. You've had the full growth and development phase. You've got a complete head and neck, you've got jaws that are strong. So to promise, straighter teeth with a Myobrace system, far-fetched, and it's not about Myobrace stopping. We have Myobrace appliances for adults to correct the functional habits, so to improve their sleep quality, to improve their breathing, to improve their nasal passage, so they're getting more oxygenation. I actually had a non-Caucasian patient who basically complained of not getting a good night's sleep, and with the fancy Apple Watches these days was testing their oxygen saturation, and in the middle of the night they'd been to an ENT, they've been diagnosed as non-sleep apnea, but was not happy with the quality of sleep which their little watch was telling them, and wore one of the Myosa appliances to correct the airway. I mean, that has no effect on function or moving teeth, and reported literally, I've got this testimonial if anybody is interested, a few weeks later, oxygen levels shot up, they were in deep sleep cycles. So really what I want to say is that yes, it's come across very much that Myobrace is looking at teeth. It's really not. Every patient assessed on habits can be a client for the Myobrace. Yes, when you're looking at what the patient wants and you're looking at correcting all these amazing things that the orthodontist does, there are certain limitations, obviously, but holistically, talking about the health of the body, the growth and development, the increased energy, the better posture, the better. I have also been in clinical practice with Myobrace a long time, and I also treated my fair share of non-Caucasian patients who absolutely benefited. So I think, yes, she's 100% right, and also the other dentist, it's a case-by-case selection. As with anything that you intervene in dentistry, it's a case-by-case selection. But the point is, there are a lot of concerns from patients, certainly in my clinic, even here in Kenya, coming in through the door every day, that I am helping. And that's, I think, a key point to take away with the Myobrace system. I hope that answered it for you. Are we still on? I think I can read a question. If you can still hear me, which is, what degree of airway obstruction needs referral to ENT? And you're absolutely right. Myobrace does not promise you to become ENTs, and there is an absolute protocol to follow, which is actually in one of the lectures on the Myobrace research. So without getting into it too much, Myobrace covers that and tells you step by step what to look for and when it's absolutely necessary to refer to ENT. So again, when you study it and you learn it, you will go and learn and educate yourself on what to look for and when to refer, which is extremely important. Are we still live, Doctor?
Doc, at what age does Myobrace stop?
The point is, it doesn't. Myobrace stops when all myofunctional habits and there are no presenting complaints from the patient. I mean, again, it's a personal thing. I speak to friends and family who snore, but don't really think of that as an issue. So to be honest, that will not be something they address. But then I see patients in the clinic and I take a full breathing and sleep history, and they tell me that they wake up restless in the middle of the night, they're tired, they're not getting a good night's sleep, and we measure oxygen and it's not the best, they don't go into deep sleep cycles. The point is, it doesn't stop.
Okay. Doctors, any more questions? Yes, Dr. Bakabulindi, they have answered your question. They have answered your question.
Yeah, so I mean, yes, the Myobrace, if you do pop onto myoresearch.com, you'll see the array of appliances. The Myobrace system specifically even goes up into adulthood. And, you know, I've seen a lot of patients, and you will have a lot of your patients who have had clear aligners, clear retainers coming in with TMJ issues that appear much later on. My eldest patient is a 93-year-old lady who said that she didn't like how she looked in the photos anymore, and has actually reported back after wearing the adult Myobrace that she's got more energy, she feels great, and she's actually one of my African patients. So the point is age is actually also up to the client, but also up to you and what you diagnose in terms of the habit dysfunctions. And yes, it does apply to patients above 45. Like I said, my eldest Myobrace patient is 93.
Okay. Doc, there are questions there.
Oh, sorry, I'm not very good with the technology of it. Oh, I've just seen that Afi Dynamics, who is the Myobrace, one clear message is diagnosis. How much interaction and consultation do you maintain with other specialists before? So yes, this is a very important question. You know, Myobrace is not promising you to overstep any roles, and you will be fully trained in all the various protocols for referrals. It's extensive. It's on its own about a 2-hour lecture available on the Myobrace website, which will go through the absolute what you're looking for, what you see. This, of course, today, a very brief touch. Like I said, if it piqued any of your interests, you know, don't take it from me. There is an absolutely free course to watch on myoresearch.com, which will guide you through the steps. But there is a protocol for referrals, and if you become a Myobrace provider, you will be given that appropriate training.
Right. Doctors, any more questions? The doctor is ready to answer. Any questions concerning the presentation?
I thank you very much for your time. I know it's a lot of overwhelming information. I think one thing Myobrace doesn't want to do is, you know, it's not deeming to be orthodontics or even functional movements. I get asked a lot of the time, it's not actually doing that. It actually has no pressures on the teeth itself. It's actually on the myosa, which are the muscles of the head and neck. So it's just resetting those pressures. I think there's a lot of information that still needs to be learnt around it.
All right, there is a hand from Dr. Trevor. Dr. Trevor, Tefula, you're welcome.
Thank you. Are you getting my audio clearly?
Yes.
Yes.
Okay. I noticed, thank you very much for your presentation, doctor. So I have one question. I noticed when you showed us the slide of the different appliances, they have the same elements, they have the same components, the same parts. So I'm wondering, patients come differently, their conditions are differently. Does the nature of the appliance change? Are there certain components that will be removed to fit the patient, or all of them have to be fixed? All of them it has to appear in that particular way for all patients? That's my question.
Yes, so this is a really good question, and I really want to take my time to explain this to you. This is the point. There is a big misconception that Myobrace is trying to straighten teeth. I don't like that, to be honest, because it's actually no functional forces on the teeth. The Myobrace appliances are just looking at correcting soft tissue, poor habits. So we're looking specifically at tongue position, as you know, reverse swallows, correcting all of that, making sure the tongue has enough space to go back into the airway, the pressures of the oral mucosa. So yes, all the appliances are designed the same, because what they are potentially doing is realigning and resetting the forces that X, Y, and Z environmentally might have caused to create this patient that's presenting with you with the poor functionals and incorrect habits. And that is the point. I think the word brace in Myobrace is very, very offensive, especially to orthodontists, you know, and I deeply want to reiterate that. It's very true. It's not meant to be. It's a Myobrace. It's only using corrections of the forces of soft tissues. So it really should never be displaying adverse effects. And, you know, so far in my training, this is what I've taken from it, but this is the reason the appliances are how they are. Then they're prefabricated, they aren't any arch form, they're not impressions of the teeth. They're actually nothing to do with the teeth, if that answers it a little bit for you.
Right. There's another question, Doctor.
I have to read it. How do you rate Myobraces compliances since it is much of the patient's effort? This is exactly the point. I mean, it is pretty much 90% of the patient's effort. And the biggest shortcoming with Myobrace, working or not working, is the patient, which is very difficult for the dentist, because if the patient doesn't listen, you don't see any results. And the patient also wants the dentist to do most of the work, to be fair. So poor compliance is the #1 shortcoming. And I think when you become a Myobrace practitioner, parent education, patient education, ongoing commitment, and also just making them understand is key. And that's just communication skills. We all became dentists because we had good communication skills, but this is really putting it to the test, because you really have to get to the patient's heartstrings, make them understand, make them persevere. It's more a marathon, not a sprint. And you know, you're dealing with correction habits. They don't happen instantaneously. So you're 100% right. It is difficult. And a comment from, you know, an absolute amazing orthodontist, just from hearing your chat, I understand the brace part is very uncomfortable, because Myobraces should not have even put the word brace. It should have been, you know, myo trainers, which is true. I agree. I mean, I wish I could tell them. I think a lot of the time orthodontists feel that it's giving education to dentists, rightly so, because of the word brace, you know, that we can afford to overlook orthodontics. It's not that, but it is talking about just the myosa. So yes, I totally second that.
All right. Doctors, any more questions? Let me take this opportunity to, on behalf of UDA, to thank Dr. Roochi Patel for a wonderful presentation. Thank you very much.
Thank you so much.
Yeah, let me take this opportunity to thank the people we organized the presentation with, Dynamics. They were our partners. Thank you very much, Kenya Dental Association. If there's any more questions, you can still ask. But people are thanking you for a great presentation, Doctor.
Thank you so much. You know, just as just as I know this is a lot of information to process, I will be asking Dynamics to email each and every one of you one of those MOE forms, just so you can have a look, and maybe even if just for your own knowledge, to start looking at function and habits, not overstepping orthodontics, but just looking at function and habits. It's worth it. It's worth opening up that field. So I will get them to email every single one of you a copy of that evaluation form just for your perusal.
Thank you very much, Doctor. And thanks everyone for attending this wonderful presentation. Thank you very much, everyone.
Thank
if there's
you.
nothing, have a good evening and have a great weekend.
You all too.
Bye-bye.